If your physical therapy fails, your doctor shouldn't just be disappointed. I mean, they should actually be taking notes.
Oh, absolutely. Taking very detailed notes.
Right. Because it turns out the exact way a conservative treatment fails is, off at a crystal ball for the operating room. Welcome to today's deep dive.
Thanks. Yeah, it's a fascinating topic today.
It really is, because for you listening, we so often think of navigating a medical issue like playing a video game, You start with the low-level solutions, the simple potions.
Right, the easy stuff first.
Yeah, like you try physical therapy, you change your diet, maybe you take some medication, and when all of those fail, you finally march into the operating room to face, like, the final boss surgery.
Yeah, surgery is always viewed as that definitive endpoint, like a binary switch.
Exactly.
You tried the conservative route, it didn't work, so now you just bypass the problem entirely with a scalpel. It feels comforting to think of surgery as this clean slate that just wipes away all the previous failures.
But then you actually step into the data, and you look at the clinical outcomes, and suddenly that clean slate is, well, it's covered in mud.
It's the absolute definition of diagnostic muddy waters.
Yeah. We're looking at a landscape today that is incredibly entangled, because the relationship between conservative treatments and surgery isn't a straight line at all.
Not even close. Because what the research shows is that the failure of a conservative treatment isn't just a dead end. It is highly predictive data.
Right.
It's actively communicating vital information about, the underlying pathology, the patient's habits, and even the structural integrity of the body itself.
Which is exactly our mission for you today on this deep dive. We are taking a massive stack of complex medical abstracts, clinical studies, and long-term data to answer a highly counterintuitive question.
Right. Can the failure of a non-surgical or conservative treatment actually predict how a surgery will turn out?
It's such a fascinating premise, because we're going to map out this entire journey for you. We'll look at exactly who fails physical therapy, why ignoring your daily habits can absolutely doom a surgical outcome.
Oh, yeah, that's a huge one.
Right, and the permanent anatomical changes that make standard repairs literally impossible, plus what happens when minor interventions just don't work.
So much to cover.
So let's start at the beginning. Before we can analyze how conservative failures impact a surgical outcome, we really need to understand the predictors of that initial failure.
Who actually fails, basically?
Exactly. Who are the patients that try conservative methods but inevitably end up on the operating table?
Well, to answer that, we have to look at a pivotal 2015 study by Lubry and colleagues.
Okay.
They were looking at female stress urinary incontinence, or SUI. And in this study, they took a large group of women with moderate to severe stress incontinence and initially allocated them to pelvic floor muscle training.
So basically highly targeted physiotherapy.
Right, exactly. And what's incredible here is the crossover rate. Nearly half of them, 49% to be exact, eventually abandoned the physical therapy and crossed over to surgery.
Almost half. I mean, that's a massive crossover rate.
It really is.
It's like trying to patch a leaking tire. Sometimes, based on the size of the puncture and the driver's daily commute, you just know immediately that a patch is going to fail and you need to go straight for a whole new tire.
That's a great way to look at it.
Did the researchers figure out what the size of the puncture was in this case? Like, what actually predicted that massive leap to surgery?
They did. They found very specific prognostic factors. First, age was a major factor. Specifically, being under 55 years old at baseline predicted a much higher likelihood of crossing over to surgery.
Interesting. And what else?
Second, the severity of the baseline incontinence was a huge predictor. They measured this using clinical tools like the Sandvik Index and the Urogenital Distress Inventory, or UDI scores.
Okay, let's unpack those terms for a second. What exactly are those scores measuring?
In plain English, they are essentially just highly detailed questionnaires. The Sandvik Index multiplies how often a patient leaks by how much they leak to create a severity score.
Okay, got it.
And then the UDI score measures the subjective impact, like how much is this condition ruining your daily life.
Right.
The worse those initial scores were, the more likely the physiotherapy was to fail and just lead straight to surgery.
Okay, well, that makes total logical sense.
Mhm.
I mean, if the literal volume of the leak is severe, a few pelvic floor exercises probably aren't going to hold the dam together.
Exactly.
But wait, I was looking through these sources, and there was another predictor that really caught my eye.
The educational demographic.
Yes. I completely understand why severe baseline incontinence predicts a crossover to surgery. But why on earth would a higher educational level predict the failure of physical therapy?
It sounds super weird at first.
Right. Like, does having a college degree somehow physically change your pelvic floor muscles?
Not at all. And what's fascinating here is that this specific predictor likely has absolutely nothing to do with physiological differences.
Okay, so what is it then?
It highlights that failure isn't always biological. If we connect this to the bigger picture, a higher educational level in clinical studies often correlates with different behavioral expectations and patient advocacy.
So you're saying it's more about how the patient chooses to navigate the healthcare system.
Precisely. Patients with higher educational backgrounds often have, different expectations for their baseline quality of life.
Yeah, oh, I see.
They might be entirely unwilling to accept a partial improvement from physiotherapy. If physical therapy makes them 50% better, they might view that as a failure, whereas someone else might view it as a success.
Right, they want a complete fix.
Exactly. They advocate for what they perceive as a definitive long-term solution, which in their minds is surgery. They just have the resources and the agency to push for that crossover. So the failure of the conservative therapy in this specific demographic is a failure of the treatment to meet the patient's lifestyle expectations, not necessarily a mechanical failure of the muscle itself.
That is such a vital distinction for you to keep in mind as we go through this. Sometimes the failure is biological and sometimes it's behavioral.
Exactly.
But what happens when the behavior is actually driving the biological failure? Because once a patient moves from a conservative treatment to a procedural intervention, they aren't automatically in the clear.
Far from it. And this brings us to a really critical rule of surgical intervention.
Yeah.
If the root cause that made the conservative treatment fail isn't addressed, it will actively destroy the surgical outcome too.
I saw a really interesting section in the notes about this relating to chronic coughing. The sources were looking at treatments for vaginal relaxation syndrome and stress urinary incontinence,
Mm-hmm.
and they specifically mentioned using lasers to tighten the pelvic tissues. How does that even work?
Well, you're referring to energy-based devices, specifically the ERYAG fractional laser therapy?
Bird by AG Tech.
Right. The ERYAG laser operates at a very specific wavelength, 2940 nanometers. It interacts with the water in the vaginal tissue, gently heating it to cause microthermal damage.
Damage. That sounds bad.
It's controlled damage, and that stimulates something called neochalagesis.
Which means the creation of new collagen.
Exactly. It forces the body to create new, tight collagen fibers, which tightens the vaginal walls and the endopelvic fascia.
Okay, and the endopelvic fascia is?
It's essentially the connective tissue hammock that holds up the pelvic organs. When you tighten that hammock, you improve the symptoms of laxity and incontinence.
That makes sense.
And the clinical outcomes are generally quite good, but there is a massive caveat when it comes to patients with a chronic cough.
Yes, the clinical FAQ text we reviewed tackles this head on because there's this pervasive myth out there that surgery or, a major laser procedure is always stronger than whatever the body is doing to it.
Yeah, it's a huge misconception.
People think, oh, my Kegel exercises didn't work because I coughed too much from smoking or asthma, so I'll just get a laser treatment or surgery, and the surgery will be immune to the coughing.
And the clinical reality completely shatters that myth. The text explicitly states that clinicians must not assume vaginal looseness is only a local tissue issue if symptoms are repeatedly triggered by a pressure driver.
A pressure driver, that's a great visual.
It's incredibly accurate. Coughing, straining, heavy lifting, extreme exercise, these all act as relentless pressure drivers.
Right.
When you have a chronic cough, every single time you hack, you are loading the pelvic floor with a massive amount of downward force.
Oh, true.
Yeah. The clinical guidance states clearly that absolutely no procedure can promise durability if repeated strain continues.
So it's basically a dam and floodgates scenario.
How so?
Like, if a patient abandons their conservative cough management, maybe they stop taking their asthma meds or they refuse to quit smoking. Doing a pelvic surgery or a laser tightening is essentially building a multi-million-dollar concrete dam, but leaving the upstream floodgates wide open.
Oh, that's exactly it.
It is absolutely destined to break. The repeated downward pressure of the cough will literally stretch out that brand new collagen or just rip the surgical sutures right out.
Exactly. The failure of the conservative cough management perfectly predicts the failure of the surgical intervention. You simply cannot outoperate a continuous, unmanaged pressure driver.
Okay, let's unpack this a little further.
Yeah.
Does this mean surgeons should outright refuse to operate if a patient hasn't successfully managed their chronic cough? Should they just send them away?
Well, this raises a really important question about multidisciplinary care. It doesn't necessarily mean refusing care completely, but it absolutely means redefining the sequence of care.
Right, the timeline.
A responsible surgeon has to explain when treatment should wait and why pressure drivers must be managed first. It requires bringing in a pulmonologist or a specialized physiotherapist to get the cough under control before the gynecologist or urologist attempts a structural repair.
So you have to treat the whole person.
Exactly. Individualized, holistic treatment is the key here. You treat the pressure driver conservatively first, and only once that succeeds do you stabilize the structure surgically.
So the conservative failure acts as a giant red stop sign for the surgeon.
Precisely.
But what about when conservative treatment fails, not because of an ongoing behavioral habit like coughing, but because of a fundamental, irreversible structural change?
Right. This is where we enter what the literature calls the orthopedic reality.
The orthopedic reality.
Yeah. Sometimes the sheer scale of the anatomical failure predicts that standard surgeries will just never, ever hold.
Our deep dive takes us into the Journal of Biomedicine and Translational Research, looking at a condition called levator-ani avulsion, or LAA. For those listening, this is a major muscle tear that is most often sustained during vaginal childbirth.
Yeah, the levator-ani muscle is a crucial foundational part of the pelvic floor hammock. An avulsion means the muscle has literally been torn right off the pubic bone.
And the longitudinal data on this in the sources was frankly staggering.
Yeah.
They followed patients from 4 years all the way up to 23 years postpartum.
It's a huge timeline.
Yeah, and the clinical reality they found was that levator-ani avulsion has a 0% healing rate.
0%. It never heals.
Wait, I have to push back on that. 0%. I mean,
Yeah.
bones heal, skin heals, even nerves can regenerate over time. Why is this specific muscle entirely incapable of healing itself?
It's a great question, and it really comes down to the mechanics of the injury. When the levator-ani is torn off the bone, the muscle belly retracts. It snaps back like a broken rubber band.
Oh, wow.
Yeah. Because it's no longer attached, it loses its tension. And a muscle without tension quickly atrophies. It then undergoes a process called fatty degeneration.
Meaning the muscle turns to fat.
Exactly. The muscle tissue is literally replaced by fat cells. Fat cannot contract. It cannot hold tension.
Right.
The researchers explicitly liken it to a severe orthopedic-style injury. It's akin to a completely torn rotator cuff in the shoulder that retracts and will just never, ever spontaneously reattach on its own.
And because that muscle never heals, it leaves a permanent gap. The data showed that this injury acts as a hernial portal.
Yes, a hernial portal.
It permanently enlarges the levator hiatus, which is the opening in the pelvic floor, by an average of plus 6 square centimeters.
Right, and that 6 square centimeter gap is the exact reason why this predicts surgical failure. The research introduces something called the PEACH concept. P-E-A-C-H.
Okay, what does that stand for?
It stands for pelvic elevator changes. The core tenet of the PEACH concept is that muscle failure precedes fascial failure.
Okay, pause. Visually, what is actually happening inside the pelvis here? If a surgeon goes in to fix a prolapse caused by this tear, why does it fail?
Well, because surgeons traditionally perform what we call a native tissue repair. They take the patient's existing fascia, the connective tissue, and stitch it back together to lift the organs.
Okay.
But remember the PEACH concept. The underlying muscle is what supports that fascia.
Ah, I see. It's like trying to repair a massive suspension bridge by replacing the steel cables, but completely ignoring the fact that the concrete anchor holding those cables has completely crumbled away.
That is the perfect analogy. If the surgeon just stitches the fascia but ignores that gaping 6 square centimeter gap in the muscle beneath it, the surgery is destined to fail.
The concrete anchor is gone.
Exactly. The underlying structural gap remains wide open, leaving a literal door open for the pelvic organs to just descend right back down over time.
The structural foundation is just completely gone. And what I found really compelling in the sources was the emphasis on a dose-response relationship.
Yes.
It highlighted that not all injuries are equal. But how do clinicians even know how big the tear is before they operate?
They use specialized imaging, specifically a 4D translabial ultrasound.
4D.
Yeah, it allows the radiologist to see the muscle in real-time, three-dimensional space while the patient flexes or bears down.
Oh, that's wild. So if a radiologist does that ultrasound and reports like a minor partial defect of the muscle, that carries a very different weight than if they report a complete bilateral avulsion where both sides of the muscle are ripped off.
Exactly. The data showed a nonlinear exponential curve of failure. It tells the clinician that if you see this massive unhealed tear on the ultrasound, you cannot rely on standard conservative surgeries.
Right, because the conservative path has already failed at a structural level.
Yes, you have to escalate your approach, perhaps considering surgical mesh or highly complex reconstructive techniques, because the patient's native tissue is definitively compromised.
Okay, so a massive muscle tear is a permanent dead end for simple repairs.
Yeah.
But is a conservative failure always a tragedy? What if a minor procedure failing is actually the only way to figure out what's really wrong?
This is a crucial pivot, because minimally invasive failures often serve as vital diagnostic stepping stones.
Right.
If a minor procedure fails, it might just be pointing the exact way forward for the next major surgery. We saw two distinct examples of this in the clinical abstracts. Let's look at endometrial ablation first.
What exactly is an endometrial ablation?
It's a minimally invasive surgical approach used to treat extremely heavy menstrual bleeding. Essentially, the surgeon uses heat, cold, or radio energy to destroy the endometrium, the inner lining of the uterus, to reduce or stop the bleeding.
Okay.
It generally has fantastic success rates. However, in a small cohort of patients, it fails to achieve symptom relief, particularly when it comes to pelvic pain.
But when it fails to stop the pain, it is a massive red flag for the pathology department, right?
Exactly. The abstract showed an incredibly strong association between failed endometrial ablation and persistent pelvic pain. When these specific patients eventually required a full hysterectomy to stop the pain, the pathology specimens revealed something fascinating.
What did they find?
The patients didn't just have surface bleeding issues, they had deep underlying conditions like adenomyosis, leiomyomas, and endometriosis.
Okay, let's define those for the listener.
Sure. Leiomyomas are fibroids, essentially benign muscle tumors in the uterus. Endometriosis is when tissue similar to the uterine lining grows outside the uterus, causing severe pain.
Right.
And adenomyosis is when that lining tissue actually grows deep into the muscular wall of the uterus itself.
So the ablation only burned away the surface, but the real pain was buried deep inside the muscle wall or outside the uterus entirely. The failure of the ablation actually unmasked the deeper, more sinister pathology.
Yes. And there's a clinical catch-22 here that makes this so tricky. Once you perform an ablation, it severely scars the uterine cavity.
Because you essentially burned the inside of it.
Right. And that intense scarring makes it incredibly difficult, sometimes impossible, for a doctor to properly assess the inside of the uterus afterward with a standard ultrasound or a hysteroscopy camera.
You just can't see through the scar tissue.
Exactly. So when the ablation fails and the pain continues, a subsequent hysterectomy becomes not just therapeutically necessary to stop the pain, but diagnostically revealing. The failure of the ablation was the only indicator left that the disease process was much deeper than just the surface lining.
Here's where it gets really interesting for me. If a failed ablation almost guarantees we'll find adenomyosis or endometriosis later, are these quote-unquote failed conservative treatments actually just necessary stepping stones?
What do you mean?
Like, if a patient has heavy bleeding and pain, should a doctor just say, well, the ablation will probably fail and we'll have to do a hysterectomy anyway, so let's just skip straight to the hysterectomy?
It's a tempting logical leap, but medicine absolutely requires escalation. We cannot ethically or practically jump straight to major irreversible surgeries like removing an entire organ without trying minimally invasive methods first.
Because for a lot of people, the conservative method does work perfectly fine.
Precisely. For the vast majority of patients, endometrial ablation is highly successful. It saves them from the severe morbidity, the long recovery time, and the significant risks associated with a major abdominal surgery like a hysterectomy.
Right.
You simply cannot predict with 100% certainty who will fail the ablation. Therefore, the failure itself is the necessary diagnostic tool. It's a process of elimination that legally and ethically justifies the escalation to a more radical surgery.
That makes total sense.
Yeah.
You have to earn the right to do the major surgery by proving the minor one doesn't work.
Yes, perfectly said.
We also saw this exact escalation principle in the data regarding failed primary prolapse surgeries. There was a highly detailed matched control study out of Leuven looking at something called laparoscopic sacrocolpopexy.
Right. Laparoscopic sacrocolpopexy, or LSCP, is a major surgery where surgical mesh is used to suspend the descending vaginal vault back up to the sacrum, the lower spine, to fix pelvic organ prolapse.
And like any surgery, it has a failure rate. some patients experience a recurrence of their prolapse down the line. I would imagine surgeons might be terrified to go back in and do a redo LSCP, right?
Oh, definitely.
Because reoperating in a pelvis that has already been cut open is notoriously difficult.
Yeah.
There's scar tissue, altered anatomy, and you'd presume a much higher risk of surgical complications.
That has always been the historical assumption, yes.
But the Leuven study completely flipped that assumption on its head. They matched 39 women who had a redo LSCP with 156 women who were having a primary LSCP. And the results were shocking.
Don't be surprising.
The redo surgery was just as safe. In fact, the early postoperative complication rates were actually lower in the redo group. It was 30.6% for the redo group compared to 41.0% for the primary group.
It is entirely counterintuitive.
Okay, let's really unpack this because I need to know the mechanism here. Why on earth would a highly complex secondary surgery in a severely scarred pelvis have a lower complication rate than the first surgery?
Well, it comes down to a few fascinating surgical dynamics. First, we have to define what they meant by early complications. The vast majority of these were what are classified as DINDO, the second complications.
And in plain English, DINDO second means what?
It basically means minor complications that require only basic pharmacological treatment, like antibiotics or blood transfusions, rather than requiring another actual surgery.
Okay.
When a surgeon is doing a redo, they know they are walking into a minefield of scar tissue. Because of that heightened risk, they are often hypervigilant.
Ah, I see.
Yeah, they might prescribe prophylactic antibiotics more aggressively in the redo group, which paradoxically drives down the rate of actual postoperative infections. Second, the primary surgery, even though it failed to hold the prolapse, might have already stabilized other parts of the pelvic anatomy.
Meaning the surgeon isn't starting entirely from scratch.
Exactly. So the heightened caution and the remnants of the first surgery actually combine to make the early recovery smoother.
That is wild.
Patients who underwent a redo LSCP were not statistically more likely to develop a severe graft-related complication, nor were they more likely to need a third intervention. The medium-term outcomes were highly comparable.
But there had to be a trade-off, right?
There was. The only significant hurdle the data showed was a higher need to convert to open surgery during the procedure. In the redo group, the conversion rate was 7.7% compared to just 0.6% in the primary group.
So they start laparoscopically with the tiny cameras, but then they realize it's too messy in there and have to make a large abdominal incision.
Right, which perfectly aligns with the realities of navigating pelvic adhesions and dense scar tissue from the first surgery. It's significantly harder to see and maneuver laparoscopically.
Right.
So occasionally the surgeon has to open the abdomen to proceed safely and not injure the bowel or bladder, but the ultimate takeaway is profound. The failure of the primary LSCP didn't mean a secondary laparoscopic approach was doomed.
It just meant the surgeon had to be prepared for a slightly higher chance of converting to an open procedure.
Exactly. The first failure informed the surgical strategy of the second attempt.
So what does this all mean for you, the listener, trying to navigate these medical realities? If we synthesize everything we've uncovered in this deep dive, the overarching lesson is a complete paradigm shift.
It really changes how you look at healthcare.
Failed non-surgical or minimally invasive treatments are not simply wasted time. They're not dead ends. They're incredibly rich, vital data points.
They are the body clearly and loudly communicating with the clinician.
Exactly. A failed course of physical therapy might reveal hidden behavioral drivers, like a patient's expectations pushing them toward a definitive fix. A failed laser therapy for incontinence unmasks unmanaged root causes, screaming that a chronic cough is relentlessly loading the pelvic floor.
And the longitudinal data shows us that conservative management simply cannot overcome irreversible anatomical damage, like a torn levator antemuscle.
Right.
The persistence of that muscular gap predicts the failure of standard native tissue repairs. And finally, the failure of a minimally invasive procedure, like an endometrial ablation, is often the exact diagnostic stepping stone needed to reveal deep-seated pathology like adenomyosis, justifying the leap to a major surgery.
It totally shifts the perspective on what a failed treatment actually is. Which leaves me with a final provocative thought for you to ponder long after this audio ends.
Okay, let's hear it.
We've seen how our bodies use treatment failures to signal these deeper systemic issues. But how might we apply this logic to the future of medicine?
It's an exciting frontier for sure.
Imagine a world where the exact speed at which a conservative treatment fails becomes a standardized, measurable metric. Like, could an AI eventually track the exact velocity of a physiotherapy failure, say it fails in exactly 14 days versus 60 days, and use that specific data point to immediately choose the exact right surgical tool or the exact right mesh for the operating room?
Oh, wow.
If failure is just data, how long until we optimize the algorithm of failing?
That is a fascinating concept to leave off on. The data is already there. It's just about how we learn to read the speed and shape of the failure.
It really is. Thank you for joining us on this deep dive into the source material. The next time you find yourself navigating the healthcare system, remember, you aren't just looking for the final boss. Every potion that doesn't work is just handing you the map to the real victory.